me still. Right in, okay.
Good morning, everybody. Hi, how are you? Yeah, everyone's so excited about their liver today. Yay! Thank you so much for coming. Can you believe this is the 6th annual Liver Expo? Dr. Reitman, good job. Amazing. So wonderful. She's so passionate about this. So I'm really thrilled that we're here again for another year. And hey, I hear you. Next year, I will have coffee. Okay. I'm so sorry. I'll do it. I will do it. I promise. That's a summer promise to you. Okay. So, going to kick this off with our wonderful program director, Dr. Marina Reitman.
Good morning, everyone. Thank you for joining us on a Saturday morning. This is going to be a fun and exciting day of liver learning. So just an overview of the program. We are going to have 3 lectures this morning. Then we're going to have a healthy lunch. And then we're going to jump into the interactive program, interactive portion of our day. And as you know, there's free FibroScan testings. There is free hepatitis C testing. There's lots of vendors. Please come say hello to them. They're looking forward to talking to you. Once you have your FibroScan in hand, please go to the results interpretation table, and our residents and fellows will be more than happy to tell you what this all means. Okay. Well, I think we'll jump into it. Oh, and my slides are here. Okay, awesome. So, who knows that fatty liver disease has been recently renamed? Show of hands. All right, we got some. Okay, so that was super confusing, right? So we used to call it fatty liver disease, or NAFL, non-alcoholic fatty liver disease. Well, there's really lots of problems with this name, right? You know, the word fatty is kind of stigmatizing. We really don't want to use it on everyone. The word alcohol is mixed in there, but you know, this is really not an alcohol related situation. And then starting the word, the name of the disease with the word non is just kind of iffy. Like, are they really not knowing what they're talking about? So anyway, lots and lots of good reasons for why we got renamed. So NAFLD is now called MASLD. And I'm going to apologize in advance. It's a little bit of a mouthful. So MASLD stands for metabolic dysfunction. The D is silent. Associated steatotic liver disease. So metabolic dysfunction associated steatotic liver disease, or MASLD. Okay, I think I'm going to get my clicker. There we go. Okay, very good. So this is an overview of this new terminology. So instead of saying fatty liver disease, which we decided is stigmatizing, we're going to say steatotic liver disease. And steatosis is another word for fat. It's just, you know, more scientific. So the overarching term here is steatotic liver disease. And now we go into our metabolic dysfunction associated liver disease, or MASL. And here we have MASL, which is the old NAFL, which is fat in the liver, but there's no inflammation and there's no progressive scarring. And here we have its more menacing cousin, which was used to call NASH, and now it's called MASH, metabolic dysfunction associated steatohepatitis. And in MASH, we not only have fat in the liver, but its fat is triggering this inflammatory response. Liver is unhappy, liver is swollen, and over years of liver being unhappy and swollen, we develop hepatic fibrosis or scarring. Okay. This is a brand new category, and it's called MET-ALD. And what was happening in the old days, we had patients, you know, who were overweight, who had diabetes, who had high blood pressure and high cholesterol. These are called metabolic risk factors. And those patients also drank varying amount of alcohol. And in the past, we had to kind of, you know, make an arbitrary decision and say, you belong in the NAFL bucket and you belong in the alcohol liver disease bucket. But in reality, you know, they belong in both buckets. So what the new terminology did is created this new bucket for us, and it's called MET-ALD. And these are the folks with cardiometabolic risk factors, plus alcohol intake. And on the low end, you can have primarily cardiometabolic risk factors, diabetes, high cholesterol, and so on, and drink a little bit. And on this end, you can have alcohol predominant liver disease, where you drink quite a bit. Next, we have alcohol-associated liver disease, or ALD. And in the gray area, it's not something that is really relevant for most of you to know. These are just kind of more rare causes of steatotic liver disease. Okay. Oops, what's happening? All right. So again, to reemphasize, so MASLD replaces NAFLD and MASH replace NASH. So the question is, what is going to happen to all the body of data and all the studies that have previously been done on NAFLD and NASH? Well, the good news, it directly translates into MASLD and MASH. There's a 99% overlap between folks who have been studied under old terminology and now the new terminology. So in terms of kind of the body of knowledge, nothing changes, which is great for us. The other great thing that all the guidelines and all recommendations from all the liver society, our home society, American Society is ASLD, or American Association for Study of Liver Disease. This directly applies to patients with new terminology. Yeah, so I think we're all good to go. The biomarkers, everything still applies. So this is really great. Okay, so the question is, who is at risk for MASLD? Is any of you in the audience, any of your friends or family members at risk for MASLD? So these are 5 what we call cardiometabolic risk factors. And the reason we call them cardiometabolic risk factors is because these risk factors not only cause liver disease, but they also cause heart disease and potentially brain disease, such as strokes. So that's why they're called cardiometabolic risk factors. So you have to be overweight or obese with a BMI of greater 25 for being overweight. We have a scale and the weight measurement in the other office, and as part of the interactive program, you can go get yourself measured and you can find out what is your BMI. The BMI is an imperfect tool. You probably have seen, super muscular weightlifters and the BMI is going to be high, but they're not at the same risk as somebody who is not a weightlifter. So another way of looking at it is the waist circumference measurement. That is something you can do at home. We're not offering it today, but this is in addition to looking at your BMI. Next, and probably the biggest risk factors, is diabetes. So if your fasting glucose is greater than 100, or your hemoglobin A1C is greater or equal to 5.7, or you already have a diagnosis of diabetes, you are at risk for fatty liver disease. So this is probably our #1 risk factors. Next one is high blood pressure. If your blood pressure is above the threshold of 130/80, or if you on medications. Next is lipid dysfunction. If our triglycerides are greater than 150, or you're already taking a cholesterol medicine, that's another metabolic risk factor. And if your HDL you probably have all seen, comes in the cholesterol panels, and HDL is classically thought of a good cholesterol. So we want to have more good cholesterol. And if it's below 40, that's another cardiometabolic risk factor. Or if you're already taking a cholesterol medication. So these are the patients who are at risk for MASLD. So what about this new category, MET-ALD? Who is at risk for MET-ALD? And basically, these are the patients with cardiometabolic risk factors who also consume varying amounts of alcohol. And I'm always asked the question is, how much is safe to drink? Well, we're going to talk about this complicated slide, but really, for any patients with liver disease, no drinking is safe, and we'll talk about why that is. But in order to fall into the category of MET-ALD, so for women, it's anywhere from 20 to 50 grams of alcohol. Now, the tricky part is, in the United States, one alcohol equates 14 grams of alcohol. I do not know who picked 14 grams of alcohol, but it's really hard to calculate. In Europe, it's 10 grams of alcohol. So that's why the guidelines look so funky. So for women, it equates anywhere from 1.5 to 3.5 drinks of alcohol. That's what makes you fall into the Met ALD. And for men, it's 2 to 4 drinks of alcohol. And the reason we created this new category is because the natural history of patients who have cardiometabolic risk factors and drink is different from the natural history from those who do not drink, despite having the same risk factors. So that's important. Now, how much is really in a drink? Like, what are we talking about? The usual wisdom is how much drinking is too much. Well, it's one more drink that your doctor drinks, but but we're not going to apply that. So if we look at beer, beer is about 5% of alcohol by weight or volume. And this is kind of your regular beer, not your fancy microbrew beer. So one drink is 12-ounce beers. So if you're at a bar and you're having a beer, you're drinking 1.5 drinks of alcohol. It's 16 ounces, a pint. So you're already above one drink. Now, as far as the wine goes, so you can see the alcohol percentage is significantly higher, 12 to 13% and probably 15 to 17% in our robust California wines. And 5 fluid ounces is a drink. Well, the 5 fluid ounces was a drink when you went to your parents' in the neighborhood diner and you got this little glass of wine, okay? Right now, when you go to a fancier restaurant and you get a bowl of wine, I'm thinking this is more than 5 ounces, okay? So a bottle of, 5 small drinks is 750 cc's of liquor. And when we talk about distilled spirits, that's where it is getting really interesting. So over here, you can see that, the most of the spirits is 40 to 45% of alcohol by volume. One shot, which is 1.5 fluid ounce, just a tiny little bit, whoops, is one drink. I apologize. Okay. If you're drinking a pint of liquor, and I know a lot of my patients drink that, it's 8.5 drink. And a fifth of vodka or whatever poison of choice is actually a whopping 17 drinks. So it's really a lot of the times the hard alcohol where patients get into trouble. Okay. Moving on. So why are excess calories bad for my liver? What is happening and why we're spending time talking about it. Okay. So these are all the excess calories that we're dealing with, right? The burgers, the candy, the donuts, the soda. So all of this is, readily available for us. Okay. So what happens is when you put all this stuff into your body and into your liver, our hepatocytes or liver cells become very unhappy. They become swollen, they become insulin resistant. So lots of bad things happen. In addition, we're putting just like plain old sugar in the body, and the body runs out of places to put the sugar and store the sugar. So as a result of it, too much fat, too much sugar, there's an excess production of something called free fatty acids. And free fatty acids are floating in our system, and they're not good for our liver, they're not good for our heart, and they're not good for many other metabolic systems in our body. So why is that specifically for the liver? Okay, so what happens is free fatty acids create what's called oxidant stress. They create inflammation. They're really not, our bodies are not designed to handle them. So when free fatty acids are floating around, we have inflammation. We have fibrinogenesis, complicated word, means scar formation. And you remember that inflamed liver will eventually become a scarred up liver. And we have DNA damage. Okay, so what happens when all of those things happen? Okay, so as far as the inflammation, we have hepatitis. Hepa means liver, itis means inflammation. And steatohepatitis means inflammation from having fat in the liver. As far as scarring, we have progressive scarring of the liver and eventually development of cirrhosis. And as far as the DNA damage lead to increased risk of developing liver cancer, such as hepatocellular carcinoma. So that is why excess calories and free fatty acid formation are bad for our bodies and bad for our liver. So how do we know if we're at risk for fatty liver? There's a few things that we can do. The first thing is a very simple score called FIB-4. Okay, FIB-4 can be calculated by your doctor with the labs that are already easily available. Basically, the doctor needs to know how old you are, what your liver tests are, and what is your platelet count. Platelet count is one of the blood components. And then all of us carry little calculators on our phones, and the FIB-4, spits out the result. Okay, so that's good. And we'll talk about what this FIB-4 result means in the following slides. So another way to figure out, how your liver is doing is with a technology called VCTE, Vibration Controlled Transient Elastography. This is a mouthful, so I'm going to use its commercial name just for the time's sake and for the sake of my tongue. It's called FibroScan. Okay, so VCTE is FibroScan. And this is a probe that fits in the palm of my hand. And this is the technology that is available to you to sample next door during the interactive portion of our conference. Okay, so what happens here is this little probe generates a shear wave. The shear wave travels to the liver and then it travels back. And by the speed of the shear wave travel, we can determine how much scarring is in the liver. Well, how does that work? How do we do it? So it's, again, a very cool technology. And if we think of the liver as a rubber ball, right? So the nice rubber ball should be very soft and squishy, like a healthy liver, okay? And if we send the shear wave through the nice and squishy liver, it's gonna take its time going through the liver. So the sound wave travel time is gonna be slow. And this is gonna equate to a healthy liver. On the other hand, if our liver is hard, cirrhotic, scarred up, like a hard ball, then the sound wave is going to travel a lot quicker through the liver. And again, the speed of the sound wave travel correlates to the degree of cirrhosis or fibrosis. What about the fat in the liver? How does the FibroScan know how much fat is in the liver? So we're back to our rubber ball analogy. And if we have a rubber ball, which is homogeneous, there's no fatty inclusion, the sound wave is going to travel through the rubber ball without getting smaller. It isn't bumping anything. So it is not going to what's called attenuate or get smaller. And that is a healthy liver. If you have fat in the liver, there's many inclusions in the liver, and the sound wave is going to bump up into these inclusions and will get smaller or attenuate, okay? And it will grow smaller, and that is going to correlate to a more fatty liver. Okay, so what happens in the end of the day is you're going to get a FibroScan report. And the FibroScan report is going to tell you how much scarring of fibrosis in your liver. And there's going to be an interpretation. And our resident doctors and fellows are going to help you understand this FibroScan report for you. So in this patient, our patient has very little scarring in the liver. By the way, the machine cannot tell between 0 and 1. We just know this is very little scarring. And it's going to tell you how much fat is in your liver. So in this patient, patient has a lot of fat. They're at stage 3, which is greater than 66% of liver cells are full of fat. That's a whole lot of liver cells that are loaded with fat. Okay, so moving on. Okay, very good. So how do we put it all together? So how do we put the FIB-4, the FibroScan in your doctor's assessment of your liver? So first of all, your doctor is going to look at FIB-4. And the FIB-4, the magic number is 1.3. And if your FIB-4 is lower than 1.3, you are good to go. it is very likely that you're just fine. And you do not need additional assessment. You don't need to see me. You're all good. And if you have diabetes, prediabetes, or other metabolic risk factors, we're going to reassess every 1 to 2 years. And if you have no diabetes and have few risk factors, we can reassess every 2 to 3 years. Now, if your FIB4 is greater than 1.3, we are going to be worried about the possibility of more fibrosis or more scarring in your liver. And then we're going to go to something called secondary risk assessment. And secondary risk assessment is going to be our FibroScan, or there's also a blood test called the ELF. Okay, so if your FibroScan tells us that you are intermediate risk or low risk, you're good to go. We are going, if you're low risk, you're going to go back to this, every, 2 to 3 year assessment. So this is good. But if you're high risk or an intermediate risk, based on the combination of high FIB4 and high FibroScan readings, then you are going to need hepatology care. We're going to need to figure out what is going on with your liver and how we can help your liver. Okay. And last but not least, if your FIB4 is significantly high to begin with, it's greater than 2.67, then you are automatically will be directed into the hepatology care. So all of this can happen in the primary care setting. So this is super easy for your doctor to decide that. Okay. So if you do get referred to the specialist, what will the specialist do? Okay. So we've determined that you are at high or intermediate risk of liver scarring. So if you see your specialist, there may be a consideration of liver biopsy. If we're not convinced what is harming your liver, maybe there is a different condition such as autoimmune hepatitis, or the previous 2 tests do not make sense clinically. So liver biopsy may be considered, but it's pretty rare these days. Okay. And then if you have very little scarring, we're going to send you back to your primary and you're going to be good to go. If you stage 2 or 3, or if you're stage 4, you are going to stay with a hepatology care. We may consider medication therapy or potentially weight reduction surgery. And for patients with cirrhosis, we're going to activate cirrhosis-based management. Okay. And again, this is just a different bypass if you are at high risk for cirrhosis. Okay, so what is happening with alcohol consumption in the United States? So since the pandemic, and really even before the pandemic, patients were drinking more. So this is a graph that shows initially in the late 80s, alcohol consumption went down pretty significantly. And then it steadily crept up, as far as 2021. So in 2019, the average patient drank 2.38 gallons of alcohol. And in 2021, we went to 2.51 gallons, which is a 5.5 increase just since 2019. I mean, that's a lot of increase. So you may think, maybe it's happening, in Arizona, maybe it's happening in Appalachian, but it's surely not happening to us, and it's surely not happening, all over the country. Well, this is the map with the red states where the alcohol consumption has increased. So it is a problem all over the country. Okay. This is hot off the press. This is something that I read yesterday as I was finishing up the slides. This is a worldwide study that looked at increasing risk of alcohol-associated liver disease in young women. And it's all over the world. And I have to tell you that here at UCSF Fresno, we were the first to notice back in the beginning of the pandemic that alcohol consumption and therefore alcohol-related disease has increased in young women. And, it is unfortunate to see that is true all over the world. Okay, so why are we talking about alcohol? What happens? So this is a 1.1 million study of the US veterans with steatotic liver disease. So up here, no alcohol consumption. we have an incidence of cirrhosis of 0.5 per 100,000 person years. This is the high risk alcohol consumption, 0.76. Well, those numbers don't seem that different, right? But what they actually translate to is the high risk alcohol consumption is associated with 43% greater risk of cirrhosis compared to alcohol use, no alcohol use. So we used to think that a little bit of red wine was good for your heart, right? Well, since then, we realized that those studies were funded by the wine industry. So we do need to take it with very, very large grain of salt. And really, if you have liver disease, you should not be drinking. Okay, how do we put it all together? So if you're looking at a patient or your doctor at looking at one of you and one of your family members, and you fall into the MASL category, if you are MASL predominant, you drink a little bit, but you have uncontrolled diabetes, your cholesterol is really high, we're going to certainly manage your metabolic risk factors. That's going to be our number one priority. But we're not going to forget about alcohol. We are going to ask you questions, screen for alcohol dependence, and get you to treatment if it was necessary. We'll screen for liver scarring, and we'll treat with disease-modifying liver drugs. And I'll talk about that in a second, okay? What if it's alcohol predominant? The same is true. We are going to primarily screen and treat alcohol use disorder. We will still work on your metabolic risk factors. We will still screen for liver scarring, and we will still offer you disease-modifying drugs. So what about the disease-modifying drugs? For many years, and certainly for many years of me doing this expo, I stood here and I told you, you must lose weight, you must exercise, and you must eat healthy. And you still must do all those things. The drugs are an add-on, they're not a magic fix, okay? So the first drug is something called semaglutide, and you might be familiar with it under the name of Ozempic and Wegovy. And at this point, these medications are approved for treatment of diabetes as well as weight loss. So there was a study looking at semaglutide, which is the component of the generic name of those drugs, published in a fancy journal, New England Journal of Medicine. And it showed that indeed we nicely reduced the fat in the liver, but we did not reduce the scarring of the liver. And it's the scarring of the liver that ultimately kills you. So I think, probably the time will come for these medications. They may need to be studied longer. They may need to be in combination with other drugs, but this is something very promising. Now, the drug is actually approved for management of steatotic liver disease with fibrosis is called resmetirom or Resdifra. And this is again published in England Journal of Medicine. And it shows that it had reversal of fibrosis and reversal of steatosis. So this is the first drug that we can use for patients with liver scarring at stage 2 and stage 3. So this is really exciting. And again, in conjunction with exercise and diet. So back to our primary care, to our specialist assessment, this is the tools that we can use to help patients now. And I'm hoping that even in a primary care setting, your primary care doctors in the near future will be able to help you without sending you to the specialist. Okay. So far, we've learned that we have new nomenclature. We've understood why this is a better nomenclature. We have new guidance algorithm for diagnosis and treatment, which your doctor and your specialist can use. We understood the effects of alcohol, and we are now familiar with MET-ALD as a new terminology. And we're going to treat patients with MET-ALD for both alcohol use disorder as well their metabolic syndrome. And we certainly have disease-modifying agents that are here now, and hopefully more will be coming through. And that's it. Thank you. Okay. We're gonna do questions as a panel at the end of it. So please write them down, hold your questions, and we'll have plenty of time to ask those questions. Now I'm going to introduce Dr. Kumari. So Dr. Kumari is is a transplant hepatologist. She spent many years at Stanford taking care of patients with advanced liver disease who needed liver transplant. And we are very fortunate to have her today to talk about the role of transplant in steatotic liver disease. Dr. Kumari. Okay. Hold on, we are going to reassemble.
Next slides will be. It looked okay on my end.
I think it's different in different.
Yeah, but I thought we fixed that possibility.
Let's do a test.
Hello. Good morning, everybody. Thanks for being here, and thank you, Marina, for putting up a very wonderful liver expo. It's helpful for a lot of patients, and this is about bringing care directly and information directly to patients. So this is amazing. So today we are going to talk about liver transplant in MASH cirrhosis. So Dr. Reitman already talked about MASH, what MASH means. So I'm not going to delve into that. So we're going to directly go into liver transplant in advanced liver disease in MASH patients. So apologies for the slide. I don't know why it came up like that. Okay, so why are we all in this room today? And as Dr. Reitman said, there is huge economic and also healthcare burden because of MASH liver disease. 100 million people are affected with MASH at this point, and out of which mathematical models were used, and by 2030, there will be a huge increase in liver disease burden leading to cirrhosis, liver-related deaths, and also liver cancer, because of which we need to start taking preventive care so that we don't reach to that stage by 2030, actually. So let's start with a clinical scenario. So one of my patients has been recently diagnosed with cirrhosis of the liver, where 75% of the liver is scarred. So my patient asked me, wait, am I gonna die tomorrow? Am I gonna die in 5 years? Is something gonna happen to me in 10 years? What is my prognosis? That is his first question. And that's always the first question that my patients ask me when they're diagnosed with cirrhosis. The second question is, will I need a transplant? Will I need a transplant tomorrow, in 5 years, in 10 years? And is there something I can do to prevent the need for a transplant at this stage? And once they're getting a transplant, the other question my patient asked me is, what are the complications during the transplant and after the transplant? And the last but not the least is, what if I get a transplant and what if the disease comes back? Will I need a transplant again? So let's go over each question and how we can fix and learn more about it. Before I go to explain to my patient takes a pause and asks me, hey doc, I have a wedding coming up. Can I have a cup of alcohol, or can I have a cup of cake or a cupcake? What is it going to do to me since I have cirrhosis? Now remember, this patient, he's not in early stage. He's in advanced stage of liver disease. And not to scare you guys, but that's how fatty liver disease with cirrhosis looks like. Your liver is normally supposed to be soft, like the ball that Dr. Reitman showed. And then with fat deposition, it becomes really hard and rubbery, actually. So as Dr. Reitman was saying, there are certain factors that can affect the course of the disease, even once you develop cirrhosis, out of which the two most important factors are obesity and diabetes. Now, obesity is a very grand general term. Now, what is obesity, and where and at what point should you be concerned? And once you have cirrhosis, what is the amount of weight gain that it can cause further progression of liver disease? So once you have cirrhosis, if you gain more than 5 kilos of weight, it leads to severe progression of liver disease. And then you go to a point of no return where you will need a transplant. It also increases risk of liver-related complications and liver cancer. So it's very important once you're diagnosed with cirrhosis to start working on weight loss and also lifestyle measures that we talked about. I'm going to go to the last point here, from obesity to sarcopenia. How do we do this?
Oh, no, okay.
Yeah, I need to press harder. Okay, so to sarcopenia and frailty. So every time you walk into a physician's office, everybody's saying you need to lose weight, but how much weight do I lose? And also when you're losing weight, the biggest thing that we don't pay attention to is we are also losing muscle. So the muscle mass, we're losing the muscle mass. So when you lose weight and also lose the muscle, that is called sarcopenia. And not only that, when you're trying to lose weight, you're also becoming weaker and weaker. You're not walking that much. You also start losing muscle strength, and that's called frailty. So being obese and also having sarcopenia and frailty triples your risk of death once you have developed cirrhosis, or increases your risk of liver cancer and also liver-related problems once you have cirrhosis. So you need to lose weight, but also have high protein diet so that you don't lose the muscle mass, and also be physically active. So these three things are really important. Diabetes is the second most important risk factor that can cause further progression of your liver disease once you have cirrhosis. Poorly controlled diabetes can cause fourfold increased risk of complications from liver disease and can cause twofold increased risk of liver cancer once you have cirrhosis of the liver. So controlling diabetes is very, very important. High cholesterol, high blood pressure, as Dr. Reitman mentioned, are other risk factors that can double your risk of having progression of liver disease once you have cirrhosis. All the risk factors we talked about lead to cardiovascular disease. While you're waiting on the transplant list, there is increased risk of complications, especially with fatty liver disease, if you develop cardiovascular disease, heart disease. So it is important to control other factors so that you don't develop cardiovascular disease while you're on the waiting list for the transplant, or if you're diagnosed with cirrhosis. Last but not least, no drop of alcohol, no smoking is recommended once you're diagnosed with cirrhosis based on the factors we just went over in the past, in the previous slides. Smoking in general increases risk of cancer, and especially if you smoke in the setting of cirrhosis, it can double your risk of forming more liver cancers, new liver cancers, once you have cirrhosis. And alcohol acts as a synergistic effect. It acts with synergy with the fat that you have in the liver to cause further progression of liver disease. A lot of information, but back to basics though. So I'm not going to go over the entire slide, but salient features. So when you walk into physician's office and they say weight loss is important, how much weight loss is important? How much weight do I lose? We know that we should not gain more than 5 kilos of weight, or we should not gain weight at all once you have cirrhosis. But the magic number is 10%. If you lose 10% of your current body weight, then it can help in stabilization of disease, or it can also help in regression of that scar tissue. So 10% is the magic number. The next question is, what kind of diet do I follow? So Mediterranean diet is highly recommended. It has been proved in several countries, in several studies at different age groups, at different stages of the disease, that it helps in preventing progression of the disease. And how much physical activity is important? The guidelines recommend 150 minutes per week, but I tell my patients 10,000 steps, because if I tell them 10,000 steps, they will at least do 5,000 steps. So I think 10,000 steps is the best to do, but if you can do at least 5,000 to 10,000, I would recommend that. So you're trying to lose weight, you do the Mediterranean diet, you're doing physical activity, but if you're still not losing weight and your BMI, which is calculated by using height and weight, is still above 40, what do? Right? Is there any other solution for this? Because now you're at risk of progression of your liver disease. That's where surgery comes in, bariatric surgery. So what is the role for bariatric surgery in patients who already have advanced liver disease? There are two kinds of bariatric surgeries. One that is done through endoscopy. They are not currently used or FDA approved, or they're not used in any of the guidelines to be used for fatty liver disease. The two most significantly studied bariatric surgeries are gastric bypass, and then sleeve gastrectomy. The difference between both of them is, if you have advanced liver disease and are going to get a liver transplant, this is not the surgery for you, because this causes malabsorption of the immunosuppressive medications and decreases the levels of the drug levels and can increase the risk of rejection. So gastric bypass is not the surgery for you if you're going to get a liver transplant. Sleeve gastrectomy is performed either before transplant or during the liver transplant. 80% of your stomach is stapled out, and you only have 20%, sorry, stomach. Did I say liver? No. Okay. 80% of your stomach is stapled, and you only have 20% of your stomach, which is used for, which is functional stomach, basically. And this is reversible. This is not like a permanent thing. So for liver disease, with advanced liver disease, sleeve gastrectomy is the preferred surgery. And actually with the surgeries, it has been proven to be more beneficial than lifestyle changes. But with every surgery comes with its own morbidity and also complications during and after surgery. So we only save it for patients who have a BMI above 40 or a BMI between 30 to 35 with the risk factors we talked about, like heart disease or diabetes and other complications. So out of all the factors that we talked about, which can affect your progression or while you're waiting for the transplant list, the key feature to remember is lifestyle changes. It's simple, it's free, and it's at everybody's doorstep, and anyone can adopt it. So lifestyle changes will prevent progression of disease or keep your disease stable, actually. So 10 years later, our patient unfortunately was non-compliant and presents with advanced liver disease. Now he knows that the only option is a liver transplant. And he asked me, what is my chance of getting a transplant? What are the risk of complications during and after a transplant? So your chance of getting a transplant depends on which part of the country you are in, and also how sick are you. So we can have a patient who is on the transplant list for 4 years with a liver score. The magic score is 15, with a liver score of 15 to 20, who is on the transplant list for 4 to 5 years. But then there is a patient who walks into a clinic with a liver score of 35 to 40. He goes to the top of the liver list within 3 days and he gets transplanted. So it is not first come, first serve unless there is presence of liver cancer. So the magic number at which you're placed on the transplant list is at 15 to 20. But the point at which you get a transplant in California is between 35 to 40. But if you're in Florida, Midwest, Minnesota, you get a transplant with a score of 18 to 25. You can get double listed. You can get listed in California. You can get listed at other states, but pending insurance, social situation, and everything. So it depends on the score and it depends on the region where you reside, actually. Donor liver, there is huge shortage of livers. There is only one liver available for every 5 patients. So we have been using, and this is not because we want to get everybody transplanted, getting a transplant when patients are in ICU, hooked onto dialysis machines, intubated, we have been using livers that are submarginal, and we have studied them and we have seen that after transplant, the outcomes are the same. So if anyone is on the transplant list, they might get a call in the middle of the night. Hey, there is a liver which has hepatitis C or Hep B, or there is fatty liver. There is a fatty liver. Do you want to take the fatty liver? So the question is, do we give a fatty liver to a fatty liver disease patient? And the answer is yes. So studies have shown that even though there is a caveat there. You don't want to give a liver that has more than 30% of fat, though. So if you give a fatty liver to a fatty liver disease patient and the patient follows all the recommendations, we have seen that the outcomes are almost as good as the regular liver. So the outcomes are really good. So if in the middle of the night, you guys get a call, it's about being in ICU, right? Being sick or taking the livers whose outcome is as good as the normal liver. And while you're on the transplant list, we talked about this, having heart disease or sarcopenia or obesity can increase the risk of complications while you're on the transplant list. So taking care of yourself is also important while you are waiting for that liver to come by. So our patient is on the transplant list, and then he asks us the question, what is the risk of my complications in the OR though? What is going to happen to me in the OR? So again, the same 3 factors come into play. Obesity. In the OR, if the BMI is above 40, it's very hard for surgeons to close the belly. So they leave the belly open and they have to take the patient back to the OR every 2 days to wash out the belly. Eventually, they can close the belly within 2 weeks or 3 weeks. That increases the risk of infections and problems from infection. So again, goes back, the reason I'm saying all this is prevention is cure, right? In order to prevent obesity, to prevent all these problems. Even in the OR, being obese is a huge problem. And if you have heart disease, there is increased risk of complications even in the OR. Sarcopenia, if you're weak, if you're frail, then it is very hard to get out of the hospital. You get a transplant, but if you're not strong enough to get up and walk, it takes longer to get out of the hospital. So while you're waiting on the transplant list, it's really important to be active, to eat high protein diet, and actually having a late night snack really helps fatty liver disease patients. Having a late night snack of up to 150 to 710 kilocalories is really important. And the protein in your diet should be at least 1.2 to 1.5 grams per kilogram per day. That really helps in building your muscle mass. And as age increases, there is increased risk of complications in OR. But having said that, we have done transplants with patients who are even 75, 78. Actually, we transplanted an 81-year-old patient. But I'm not saying that transplant is the answer for everybody. But if it has to be done, it has to be done. But again, prevention is the best thing. So that is in the OR. What else affects your outcome after transplant? Again comes the heart disease. The first 5 years, patients with fatty liver disease who get a transplant are affected with heart disease the most. So again, controlling your risk factors is important. infections because you're on rejection medications, anti-rejection medications, and cancers. So it's really important if a patient is there who is getting a transplant to apply sunscreen, not to be exposed to direct sunlight, and also to get dermatological skin checkups done every 2 to 3 years, getting pap smears every year, mammograms every year, and colonoscopies every 5 years, and prostate checks done every year. It's really important, again, prevention to early diagnose and cure this. So this is a very genuine question. You go through all this, then what is the chance of the disease coming back? How do we diagnose it? How do we treat it? And how do we fix it? So the same factors that affect your disease in the pre-transplant setting are the ones that affect you in the post-transplant setting, except we are adding one other factor here, which is the post-transplant medications. So the medications that are used as anti-rejection medications can cause high blood pressure, cholesterol, high cholesterol. They can cause kidney disease and heart disease. So that adds an additional factor because of which 80% of patients after transplant can develop fatty liver disease within 5 years. And before transplant, the disease progresses at a very slow rate of every 5 years, there might be an increase in additional stage of scarring. But after transplant, within 5 years, you can get cirrhosis, advanced liver disease. So again, prevention is important. Identifying the cause is important, and fixing it early on is important. That's why annual blood work is important. Getting cholesterol check, blood pressure check, weight checks, thyroid checks is important. And annual ultrasound, early recognition and treatment is important. So then my patient asked me, what if I have recurrent NASH and there are approved medications? Can I use them after transplant? These are the medications that Dr. Reutemann just mentioned. These medications have not been studied in the transplant setting, but they can still be used in the transplant setting. There are no drug-to-drug interactions, but the drug levels, they need to be monitored very carefully though. So overall, there is an increase of fatty liver disease burden in our community now, and it is only going to triple or quadruple by 2030. Liver transplant is the only choice if the liver score is 15 to 20 in the setting of advanced liver disease. There is significant prevalence of cardiac disease if you have advanced liver disease or cirrhosis. NASH recurrence can happen even after transplant, and it happens that about 80% of patients develop it by 5 years. Prevention is always better. Either pre-transplant or post-transplant, prevention is very, very important. Again, the liver doctor has to work along with primary care physician. In that multidisciplinary team, the most important person is the patient. So everybody has to work as a team to get the good outcome. Thank you.
Do you want the lavalier? Mike. I know, sure. No problem. Turn out this light. It's on the bottom. Okay, all right. There you go.
Okay. Hi, everybody. We have one more exciting lecture for you. I'm going to introduce Dr. Rangel Garcia. Dr. Rangel Garcia is a gastroenterologist by training. And the exciting thing about her, she is a Central Valley native. She was away for training and she is back to take care of us. Give her a round of applause.
Okay, so I'm going to talk about the burn. You may all know it, the heartburn that we feel, also known as GERD. Thank you so much. How do I move forward? Sorry.
So this is the advance and this is the
Perfect. Thank you. And I'm going to talk about PPIs because I think that we hear a lot about PPIs, proton pump inhibitors, in the media, and I think there's a lot of questions about their safety overall. So I can talk forever about that, but we have a limited amount of time, so I'm just going to try to address those concerns. Okay. So what is GERD? Gastroesophageal reflux disease. It's really a simple definition. It's the backflow of acid contents from the stomach into our esophagus. It is objectively defined, meaning that there's evidence for it, that we can see on endoscopy. We can also measure and find out if there's an abnormal amount of acid in somebody's esophagus. And I will talk about that later, but there are ways that we can define these things. And so we can, on endoscopy, look for inflammation caused by GERD. And then, like I said, there's measurements that we can take to look for pathologic or abnormal acid in somebody's esophagus. So some of the numbers, the epidemiology, GERD is much more common amongst patients who suffer from obesity, who are pregnant, and elderly patients. It's one of the most common diseases seen by primary care physicians and gastroenterologists. I have a lot of referrals from primary care doctors for patients who have been diagnosed with GERD, or the thought is that they do have GERD and they are not getting better from their PPIs. Up to 20% of the United States population can have GERD. That's a huge, huge number. So that's 1 in 5. So there are many of us, including myself in here, who sometimes has these heartburn symptoms. And the economic burden is huge. So $20 billion annually. A lot of that is from frequent visits to the primary care doctor. Sometimes people go to the emergency room for chest pain. They think it can be their heart. That's very scary. And so they go and they're told it's actually not your heart. You have a really bad GERD. You need to go and see your primary care doctor, and you need a referral to a gastroenterologist. So because of those frequent visits, also because of the use of different medications, proton pump inhibitors, H2 blockers, that also kind of contributes to this economic burden as well. Okay, so symptoms of GERD. There are typical symptoms and there are atypical symptoms of GERD. The typical symptoms are really just two. It's heartburn and regurgitation. Atypical symptoms, as you can see on the screen, sometimes it's hoarseness of voice. It can be a chronic cough, wheezing, a globus sensation, meaning that I feel like there's something always in the back of my throat. That is also an atypical symptom of GERD. Now, these more, throat symptoms are also known as extra esophageal manifestations of GERD, meaning we're not feeling the regurgitation, we're not feeling the heartburn, it's something up here. Causes of gastroesophageal reflux disease. It's really the failure of the anti-reflux barrier. And so we have between the esophagus and the stomach, or right at the connection, what's called the lower esophageal sphincter. This is disrupted when patients are experiencing gastroesophageal reflux disease, okay? So there are other things that can play a role, but this is really the most common cause. And what happens is like I said, at the connection, we have the lower esophageal sphincter. There are two parts to this sphincter. There's these inside circular muscles that that act as a barrier. And then around the esophagus, you see there's the crura of the diaphragm. So our diaphragm is the muscle below our lungs, right? It separates our chest cavity from our abdominal cavity, and it does play a role in this anti-reflux barrier. Now, for whatever reason, sometimes you can see that this barrier, these muscles are disrupted. One example up there is a hiatal hernia. So when people have hiatal hernias, part of their stomach moves up into their chest cavity above those crura, above the diaphragm. And so you really lose that barrier. I kind of describe it as a door. The door is now open. All of the acid that, was usually or normally closed off from the esophagus is just now moving straight up. And that's why you feel what you're feeling. A lot of times people also feel it a lot when they're laying down. So if you can imagine, when you're upright, you have gravity pulling everything down. When you lay down to go to sleep, that's when you're feeling everything. That it's that barrier is not there anymore. Other causes, contributions to gastroesophageal reflux disease. One of them is decreased salivary production. We see this a lot in patients who smoke. Their salivary production is decreased. Saliva helps to neutralize acid. It's one of the first steps in terms of our how we process our food. And so that is decreased. There can also be dysmotility disorders of the esophagus. So the muscles of our esophagus aren't moving normally, things aren't moving down, things stay inside the esophagus. There we have some heartburn, some regurgitation. Also, part of this can be delayed gastric emptying, also known as gastroparesis. There are many different causes of gastroparesis that I don't need to talk about today, but that also can contribute to this feeling of acid reflux disease. So how do we diagnose gastroesophageal reflux disease? The first step really, so a patient comes to me and they're telling me, hey, Dr. Rangel Garcia, I'm feeling this heartburn. I have some regurgitation. I started about a few months ago. The first thing that I ask them is if they have difficulty swallowing. So what I'm looking for is what we call red flag symptoms that can be associated with GERD. And I ask this because if somebody has these red flag symptoms, they're more alarming, and I will take a patient to endoscopy earlier than later. So the red flag symptoms: difficulty swallowing, unintentional weight loss, pain with swallowing, and sometimes early satiety, meaning I'm getting full a lot faster when I eat. All those things are alarming, and they're really more alarming for a cancer. And so I want to rule out cancer right away. So if you come to me and you're telling me that you're having any of those symptoms, I'm going to take you for an upper endoscopy. If you are just having, some heartburn, regurgitation, the first thing I'm going to do is I'm going to trial you on a proton pump inhibitor. And I will talk about proton pump inhibitors a little bit later. And what we do is we say, hey, let's try a proton pump inhibitor. I'm going to start you on the lowest dose. You're going to take it 30 to 60 minutes before your first meal of the day. And let's see how you do on that. Many patients do really well on a proton pump inhibitor. Their symptoms are significantly improved. Their quality of life has improved. They're very happy. I have them come back in about 2 to 3 months, and we talk about how their symptoms are doing. If they are better, I will try to slowly taper them off of that acid suppressant. There's really no evidence in terms of tapering versus stopping completely. Some people can stop completely, and that's okay. But I usually kind of have patients slowly stop their acid suppressant, and many times they do very well. They don't need it again. If you're telling me, hey, it's a little bit better, it's not quite there yet, there are a few things that I can do. We can increase your acid suppressant medication to twice a day. That's not, it's the PPIs aren't FDA approved for that, but in the guidelines, you can increase to twice a day a proton pump inhibitor. Otherwise, what I will do is I will say, hey, you know what? Maybe this isn't gastroesophageal reflux disease. We need to investigate a little bit more. Let's do an upper endoscopy. Okay, so on endoscopy, right on the picture on the right is, some people don't know what an upper endoscopy is. It's a very overall safe and simple procedure. We take it's like a little, sometimes I just describe it as like a little tube or a hose. It's very skinny. It has a camera at the end. Here at CRMC, where I do my procedures, I use monitored anesthesia care for almost all of my procedures. So you are asleep. You do not feel any of this. And I take my scope and I go into your mouth, into your esophagus, your stomach, and the first part of your small intestines. And what I'm looking for are objective findings, evidence of gastroesophageal reflux disease. So that picture there, you see A, B, C, and D. This is esophagitis. This is erosive esophagitis. This is actual evidence of gastroesophageal reflux disease. And there's different levels of, you can see, right? And you can see in that D level, that patient is having pain. They're definitely having heartburn. They could even be having difficulty swallowing. A, you can see there's a little break in that connection between the white esophagus and then the start of the stomach. You see a little break there. That's the earliest sign of inflammation. So that's what I'm really looking for. And then there is Barrett's esophagus. Barrett's esophagus happens after chronic exposure of acid in the esophagus. And I can talk about that a little bit more. But these are the things that I'm looking for in my upper endoscopy. Other things that I look for are, I'm asking if this patient has gastroesophageal reflux disease, I see the evidence, why are they not getting better on that acid suppressant? And what we want to look for are anatomical abnormalities that are basically like provoking or kind of causing this barrier to not work. And I talked about earlier hiatal hernia, diaphragmatic hernia. So you can see on the picture on the left, that's a hiatal hernia. And then I put that little cartoon schematic so you can kind of see what you're looking at endoscopically. You can see that, so I'm looking down from the esophagus into the stomach with my scope. I can see those gastric folds are actually coming up above that kind of like tighter area. So that tighter area, that's where the diaphragm is closing in. The stomach is coming up. That is a hiatal hernia. That's a pretty large hiatal hernia. And there you see, like, there's the acid's probably just coming straight up, right? And then the next is the hiatus grade. And this is graded, this is based on the American Foregut Society's recommendations for grading what is called the diaphragmatic hernia. And that's when the diaphragm is, like I said, open, it's not as tight anymore. And you can see on grade 1, the crura, those muscles made from the diaphragm are pretty tight around the scope, right? So nothing's really getting through. You can see that. And then you look all the way to grade 4 and you can see absolutely wide open. That door is wide open. Acid is moving up. So I look for those things on endoscopy because these things can be fixed. And also, these are reasons why I might stay or I might keep a patient on an acid suppressant. This is not going to get better once I take a patient off of an acid suppressant, right? When I see these things, and I can tell patients that, and now I can explain it to them, they can understand, their primary care doctor understands, their primary care doctor's probably not going to take them off an acid suppressant now that I have this evidence. Okay, now if I don't see inflammation in the esophagus, but the patient is still having these symptoms, and I have really high suspicion for GERD, what we can do is an ambulatory pH monitor. It's also known as a Bravo, and it is placed endoscopically. So you will do an upper endoscopy. This has to be done off of a PPI. And I do want to mention, when I do an upper endoscopy for patients that I'm suspicious for GERD, I do ask them to stop their acid suppressant at least 2 weeks before. If they can, it's difficult for many patients, but and that's because I want to see that inflammation, right? If you're on an acid suppressant doing the upper endoscopy, and this is for GERD, you don't want to be on your PPI because it's going to be masking that evidence that I'm looking for. So this is a little capsule. I attach it into your esophagus. It's not painful. Most people do not feel it at all. And then you go home wearing that little monitor that you see down there. And the capsule is sending data to this monitor. You bring back that monitor to our office and we download all the information and we interpret it. And it's going to tell me how much acid exposure time you have, meaning how much or how long was the esophagus exposed to acid? What was the measurement of the acid, the pH? And then did it correlate with symptoms that the patient was feeling? And through that, I can say, you know what? Yes, this patient has gastroesophageal reflux disease. They have abnormal acid exposure to their esophagus versus this patient has some hypersensitivity. So maybe the acid exposure time was normal, but their symptoms correlated with the acid exposure versus there's absolutely no correlation. And this patient can have functional heartburn, which is a disorder of the gut-brain interaction. And all these things actually have different treatments. So that's why it's important to investigate this more, because I don't want to keep a person on a PPI if it's not indicated for them, right? So this is something that's very easy. Like I said, it's done 48 hours versus 96 hours. 96 hours, the longer you test, the more sensitive it is. You cannot be on your PPI. And then the capsule just falls off. You never see it ever again. It can stay up. I think, patients are really concerned that there's something stuck in their esophagus. It does fall off, it leaves your body. If it doesn't fall off, we can always easily take it out. That's super, super rare. Okay, so complications of gastroesophageal reflux disease. I mentioned Barrett's esophagus. So Barrett's esophagus puts people at increased risk of esophageal adenocarcinoma, esophagus cancer. And so this is something that we definitely want to be able to identify and diagnose early. It's when the lining of the esophagus changes from certain squamous cells to columnar cells. They start looking more like intestinal cells. They don't look like esophagus cells anymore. And if somebody does have Barrett's esophagus, we have to do endoscopies at certain intervals, depending on how much of that abnormality is there. So I would recommend, hey, we're going to bring you back every 3 years or every 5 years, and we want to prevent cancer in that case. That Barrett's esophagus is also an indication for lifelong proton pump inhibitor treatment. And then there's strictures. So these are benign strictures. This is not cancer, but you can see here that, you remember that picture with the hiatal hernia, the esophagus looked wide open. You can see here from chronic inflammation, you get scarring and fibrosis, and you have narrowing of your esophagus. So people are saying, hey, I can't eat, my cereal in the morning anymore, or I can't eat like my pasta. It feels like something's getting stuck. And this is treatable. That the top picture is very, very severe peptic stricture. Rarely people have that. What we can do is we can dilate during an upper endoscopy. So it's overall very easy to treat most of the time, but we don't want it to get to this point. So let me just make sure. Okay. So treatment options, like Dr. Kumari was saying before, there are lifestyle modifications. There are no adverse effects to these lifestyle modifications. Are they difficult to implement sometimes? Yes. You have to, like I said, lifestyle, you're going to have to change some things that you do on your daily basis. but they can be very, very helpful. One thing is weight loss in overweight and obese patients. We've all mentioned it, and I think, it's very difficult, but, taking it day by day and coming up with a plan with a provider, with a dietitian, you can get there. Avoiding meals within 2 to 3 hours of bedtime as well. So like I said, when you eat and then you go lay down, all those gastric contents, that acid is going to come up into your esophagus. So it's really important to not lay down right away after eating. Elevating the head of bed at least 30 degrees as well can be very helpful. That's for that kind of gravity, assistance there. And then avoiding foods that may exacerbate symptoms. These are some of the foods that are known to exacerbate some symptoms. Everybody is different. And so you kind of have to be able to identify your triggers, because I can tell you to, stop all these things, but this might not be what's your trigger. And then avoiding smoking. And I had mentioned that earlier in terms of, smoking can decrease salivary production, which then, you have difficulty neutralizing the acid that comes up. And then there are many different types of medication. So I'm going to take a little break. So most people that come to me in the office from their PCP, they're taking some kind of over-the-counter antacid, like Tums. And this Tums basically, or antacids, work to just neutralize the gastric acid, and they can actually, be very helpful. But patients notice that, okay, yeah, like now every meal I need to take 2 or 3 Tums, and now it's 3 or 4, and so they're noticing that they're needing to take more and more. There are also H2 blockers. These block histamine from activating production of acid in the stomach. We then have proton pump inhibitors, and I will talk about proton pump inhibitors more, but these work on a certain enzyme in the stomach, the parietal cell, that pumps out acid from the cell. And so the proton pump inhibitors work on that enzyme. Then there's alginates, also known, if you see it out like on Amazon, is where a lot of people get it because it's hard to find sometime in the stores. Also known as Gaviscon, but it's a seaweed extract. And as you can see there, it kind of forms this gel barrier over the acid in your stomach to block the acid from moving up into your esophagus. Baclofen is also another medicine that's used. It's not first line at all for gastroesophageal reflux disease, but it can be really helpful in inhibiting what's called transient lower esophageal sphincter relaxation, really, really long term. But anyways, sometimes that when we swallow, our lower esophageal sphincter relaxes to help the food go into the stomach. And so what happens, that can happen abnormally too many times. And so you will have acid reflux. And then cognitive behavioral therapy and diaphragmatic breathing can be, has shown to be actually very effective and helpful for upright GERD. Okay, and then we have surgical and endoscopic interventions, and this can be a whole other topic in and of itself. So I'm just going to go over these quickly. They're very somewhat hard to see. Sorry about that. But so when do I, refer somebody for surgical or endoscopic intervention? I will refer patients to a surgeon if they have a large hiatal hernia, if they have a large diaphragmatic hernia. They might be having some complications like peptic stricture that I'm not able to completely dilate. They've been on an acid suppressant for a long period of time. I will refer them to a surgeon. Many people get very nervous about this, but it's really, it's not saying, hey, I'm going to send you because you need surgery right away. Like, no, it's just to talk to a surgeon and learn about the risks and the benefits of a surgery that for treatment of GERD. And so I like to do that sometimes sooner than later. And at least you've established with somebody, and now you have somebody to go back to and talk with when you come to the decision of, yes, maybe this is something that I want to move forward with. So there's Roux-en-Y gastric bypass that can be helpful in terms of patients with obesity. Laparoscopic fundoplication, that's where they take the top of the stomach and they wrap it around the end of the esophagus. And then there's other endoscopic interventions. So radio frequency anti-reflux treatment, also known as STRETA. This is not really, the data is very inconsistent in its effectiveness, but it was used. It's not used as much anymore, but it's basically pulsed energy to the lower esophageal sphincter muscles. The goal there is to strengthen the muscles and tighten that anti-reflux barrier. There's also magnetic sphincter augmentation, also known as LINK. So surgeons place magnets around the end of the esophagus to actually tighten the lower esophageal sphincter. And then there's a transoral incisionless fundoplication. So this is, it's also known as a TIF. It's done endoscopically. It's similar to a fundoplication, but it's not a surgery. They do it from the inside. And I have pictures of and some diagrams so you can better understand these things. So up at the top is the LINX, is the magnet that's placed on the outside of the esophagus. And then down at the bottom is the Nissen fundoplication, where the surgeons take the top of the stomach and they wrap it around the end of the esophagus. And that's really to fix that barrier that has been disrupted. Now you look up at the top to the right, and that's the same thing. It's kind of like the same thought process in terms of strengthening that lower esophageal sphincter, but it's doing it endoscopically. And then the STRETA is there at the bottom. So before I end my talk, I'm just going to, like I said, talk about proton pump inhibitors. They're the most commonly used medication in the world. They act on that pump, the proton potassium pump in the parietal cell in the stomach to pump out acid. So they block that from happening. They're best administered before food. They need a certain kind of stimulation to start working. And so one thing that I ask my patients when they come and they say, hey, my acid suppressant, that omeprazole that you gave me, I'm taking it and it's not working. First question I'm going to ask is, how are you taking it? Many times patients are taking it incorrectly, and that's why the acid suppressant isn't working. We fix that. I re-educate them on how to take it appropriately, and there you go, they're all better. And so, the proton pump inhibitors, they're actually fairly new. They first came to the market in 1989, and since then there have been several more developed. The most common ones that you'll hear are pantoprazole or Protonix, omeprazole, Nexium. You have seen them, at your neighborhood pharmacy. You can buy them over the counter. So they're very highly effective. They're once daily dose. So it's not really too burdensome. It's not something that you're having to take 2, 3, 4, 5 times a day. Like I said, widespread availability. So you can buy them over the counter. I think this is a good thing. It can also be a bad thing. And it's well tolerated overall. So there are really many patients don't have any side effects from the PPIs. What are the indications for use? I think that one thing that I try to educate my patients on, no matter what I'm seeing them for, is to really understand and empower them to know what medications they're on and why they're taking them. Many times I go through the medications and people don't know why they're taking them. And so, I highly encourage you to understand why. And it's okay to ask those questions. Your providers are there for you to help you to understand. So these are the indications for use: erosive esophagitis, GERD, Barrett's esophagus. We also use PPIs to treat peptic ulcer disease, especially in ulcers that have bled. We use them for also dyspepsia, or some epigastric discomfort that patients can present with, hypersecretory state. So there's overproduction of acid that can occur in a patient. We'll use them for that. They're also indicated for treatment of H. pylori infections, chronic NSAID use with risk of developing ulcers, and then stress ulcer, preventing stress ulcers. If we have a critically ill patient in the ICU, those patients will be started on a PPI. So when is lifelong treatment indicated? It's indicated in the really severe LA grade C and D esophagitis. You remember those pictures that I showed you. It's indicated in Barrett's esophagus, and this is to really prevent the progression of those change in cells that can put somebody at increased risk of developing esophageal cancer. And then eosinophilic esophagitis. This is more of an autoimmune condition, and patients. One of the first steps of treatment is a proton pump inhibitor. And so then there's this other question: are PPIs safe? I have a lot of patients that refer to me it's because they are having GERD, they're having severe heartburn, but their providers stopped their proton pump inhibitor for some concerns. And so they're asking me, what do we do next? And so some of the most, the more frequent concerns that I run into are bone fractures, dementia, I don't want to hurt my kidneys, and then also infections. So I'm just going to touch on these. There have been multiple studies, and I think one thing that we have to remember, and what I want to tell you, is that there are different types of studies that we do to show evidence for a certain medication or a treatment, or this is connected to this, or this causes this. There have been no studies that have shown that proton pump inhibitors cause any of these adverse effects that have been mentioned. There has been association, but these are studies that that have been presented. There's a lot of bias, and there are other explanations for why we see those associations. And so the thought process in terms of bone fractures is you need acid to help calcium absorption. So if you take a proton pump inhibitor, you're going to decrease the amount of calcium that's absorbed, and there you can affect your bone mineral density. You might increase a patient's risk of osteoporosis. Like I said, there's been no clear associations in trials. There's been a randomized controlled trial and these are the gold standard. Randomized controlled trials are like the gold standard. They're the best kind of studies that we can do to provide evidence for something. And those did not show any increased risk of bone fractures in patients who are taking proton pump inhibitors. The next is enteric infection. So the acid in our stomach is there for a reason. It can be there, it's there to help absorption. It's there to help protect us from organisms that we may ingest. So if we're going to disrupt the acid, are we going to increase our risk of enteric infections? So this is the only adverse effect of a proton pump inhibitor that has been shown in a randomized controlled trial. Yes, taking a proton pump inhibitor can increase the risk of gut infections, of GI infections. It does not increase the risk of Clostridium difficile, or how we know, some of you may know, C. diff, right? It's a very, very scary infection. It can kill you. It can make you very, very sick. There's treatment for it, however. And so patients, it was in the media that PPIs could put you at risk of C. diff infection. There's been no randomized controlled trial to say that a PPI causes C. diff infection. And even so, the Infectious Disease Society actually put in some of their guidelines that if you are stopping a PP, or if there is concern for C. diff infection, that's not enough evidence to tell somebody to stop a proton pump inhibitor, okay? And then we have dementia and CKD. So in terms of dementia, that is with the beta amyloid. You have, increase of buildup of beta amyloid in your brain. That's going to cause dementia. If we stop acid in our stomach, acid helps to activate lysosomes that can break down those amyloid proteins. And so that's kind of like the thought process behind PPIs and dementia. Again, no randomized controlled trials have shown that that PPIs put you at increased risk of dementia. And then CKD, so chronic kidney disease. PPIs have been shown to cause acute interstitial nephritis. And so the thought with this is that if you have recurrent AIN episodes, you can develop chronic kidney disease. Also, again, there has been no randomized controlled trials that have shown that proton pump inhibitors cause chronic kidney disease. And you don't need to check. I've definitely seen this, that patients, their creatinine or their kidney functions being checked on a regular basis because they're on a proton pump inhibitor. That's not indicated as either. Okay, so adverse effects. So this is some of the national gastroenterology societies came together, and they basically said, you know, all these, we understand where the concern came from. These studies are flawed. There are biases that are you know, in these studies, and there's really nothing to establish this cause and effect relationship between PPIs and adverse conditions. High quality studies have not shown any connection between these adverse effects and proton pump inhibitors. And for the treatment of GERD, gastroenterologists agree that the well-established benefits of PPIs far outweigh their theoretical risks. And honestly, I've seen multiple patients, their quality of life has really gone down when they were taken off of a PPI. They were told this is not safe, this is going to cause this, this, and this. So they're worried, and then they're suffering from the symptoms. I explain this to them. They're like, yes, please give me the omeprazole. And they come back and they're feeling so much better. They're able to enjoy their life so much more. And it can really, so I think it's really important that you understand these things. And as it's my job to try to, you know, communicate that and understand it for you as well. And so really quickly, as I end, I just want to talk about, yes, PPIs are safe, but do we always need to be on them? No. And so we have to also practice taking them out of a patient's medication list, because there is pill burden. It is very costly. And so the American Gastroenterology Association published this clinical practice update in 2022 talking about deprescribing proton pump inhibitors. And they said, you know, they are overprescribed and used longer than they are really needed. And so we as physicians really need to regularly review why a patient is on a proton pump inhibitor. And if there is no indication, we need to stop them. A twice daily PPI should be considered. So if I see somebody that's on a twice daily PPI, I really need to think about, is that needed? And can I decrease it to one? And highly encourage the patient to do that as well. A lack of an indication should be the only reason to stop a PPI. Chronic kidney disease, dementia, this concern for osteoporosis is not enough evidence to stop it if it's indicated. And they should not be stopped, like I just said, because of concern for adverse events. So overall, my key points here are GERD is a very common disease. There's a lot of different treatments for it. They include medical, surgical, and endoscopic interventions, as well as the simple lifestyle modifications. PPIs are still first step in treatment and are overall safe for use. Thank you.
Well, thank you, everyone. Thank you to our amazing speakers. This is your favorite part of the morning program, the questions. So please go ahead and ask the questions. Yes.
Hang on one second. I'm going to bring the mic.
And we'll also wait for the screen to go up since it's noisy for us.
Thank you.
Hi, two questions. Tums, if someone's taking Tums and they take them like candy because they don't go to a gastrologist and that, what is like too much and you should go to a gastrologist? And what's the actual correct way to be taking omeprazole?
Okay, so omeprazole needs to be taken, sorry. Acid suppressants need to be they cannot be taken with food. They don't work that way. They also cannot be taken, you can't take it and then not eat, because they need to be, they need a little bit of acid to actually start working. And so they need to be taken 30 to 60 minutes before a meal. And it's highly encouraged to be the first meal of the day. What I usually tell people is to do 60 minutes before a meal, because then they'll probably do it at least 30 minutes before a meal. I know that's how I function. So that's how they should be taken. You know, Tums can actually become very
dangerous, especially if patients have kidney disease as well. And so when you're taking, like 2 or 3 every meal, I already think that it's too much. It might not cause some kind of adverse effect, but you're treating something incorrectly, basically. Does that make sense? Okay.
Hi, my name is Sham. I have two-part question. So today is all about fatty liver condition, but there are also some good fatty foods. So can you break it down? What is good fat versus what is to avoid? And the second part is we are blessed to have nuts here, right? The walnut and everything, but some of the nuts are also hard to digest. So do they put additional load on the liver?
These are really great questions. And absolutely, just because we have fatty liver doesn't mean we need to limit all fats. And we mentioned earlier that a Mediterranean style diet is considered the healthiest for the liver. And in Mediterranean diet, there's lots and lots of olive oil that's being used. That's a wonderful fat for the liver. There's also fat that is contained in the fish that we consume, and those are also very healthy fats. Nuts are not hard on the liver, and nuts have many wonderful benefits. I actually talk to my patients about eating nuts, and nuts are high in healthy fats and high in protein. And the reason that is important is if you have a handful of nuts, assuming they're not, covered with all kinds of spices and salt, which we don't necessarily want to do. But if you eat a handful of nuts as kind of your midday snack, you have a healthy dose of fat and you have a healthy dose of protein. And this will actually prevent you from being very hungry at the next meal and overeating. So nuts and olive oils, again, prominently features in Mediterranean cuisine, and they are very good for you. I think our mics are running around.
Hi there. My question is this: what is the correlation between fatty liver and kidney stones?
Radhika, do you want to take this one?
I'm thinking.
Yeah,
I don't think there is a correlation between fatty liver and kidney stones, but there is a correlation between fatty liver and kidney disease, though, because the common factors that cause fatty liver, which is the steatosis, also cause kidney disease like diabetes, high blood pressure. Kidney stones happen because of recurrent infections and also lack of hydration. So I don't think they're related unless.
not that I know of.
Yeah.
Other questions? There we go.
It's recommended on this paperwork that we're given that we should not eat 2 hours before we have that scan. And we're being served lunch here. So should we skip lunch if we have an appointment for that?
That's a really good question. So I think lunch comes in a little box. So you're welcome to take lunch with you and eat it after your appointment. It probably doesn't play a dramatic role. In the old days, we could only treat patients with advanced fibrosis for hepatitis C. So we will keep it between us. But a few times I had encouraged patients to eat before the test, so I could treat their hepatitis C. And unfortunately, it did not make a difference. So this is what the manufacturer recommends, but it's probably not dramatically important.
And then the other question, it was stated to do, now I can't remember if it was 10,000 or 100,000. And was that a day or was that a week that you're
10,000 a day.
A day, okay.
10,000 steps a day. Yeah.
Shall we take a couple questions from the online?
So a 30-year-old type 2 diabetic with cardiometabolic risk factors, controlled with medication, age 71, BMI is 26, I had a FibroScan in 2022. Results are normal. How often should I repeat a FibroScan?
So this patient has multiple cardiometabolic risk factors. And I think in this patient, we should repeat every 1 to 2 years. Couple
Okay.
other, at least one more.
Sorry?
Do you have more?
Oh, no, yeah, we got a couple
Okay.
more. It says, would you please review the calculation for FIB4?
So I would have to pull up my slides, but if you Google FIB4, there is multiple platforms on which you can calculate that too. And basically, there's 4 things that are needed to this calculation: your age, your liver enzymes, and your platelets. And for the most part, when you go to the doctor checks all of those things. And this can be plugged into a very simple calculator. MedCalc is the platform that I use. It's free and it's super easy to use. Let's switch back to the audience questions.
Hi, good morning. You mentioned a lot of liver fatty on obesity people. What happens with people that they're really skinny and they have fatty liver? I have one of them is my mom, and I have a friend that she's probably like 110 pounds or less than that. And she's been trying like so many things to reduce her liver liver, and it doesn't happen. And on my mom, she's probably 135 pounds and she's 5'2", and she's been doing so many changes, but then, yeah, she still comes with fatty liver, I'm sorry.
This is a great question, and we can probably spend like the whole other day discussing that. So this is a real entity referred to as skinny MASH or skinny fatty liver disease. And we know that there's certain ethnicities that we observe that more often, specifically the Asian ethnicity. And in Asian folks, the fat is stored differently. You know, a lot of the fat is stored inside of the abdomen and called visceral fat. And this fat is very unhealthy. So the patient may not look overweight, may not be, kind of classically what we think of an overweight patient, but because of the way they store fat, their liver may be more affected. So that's one thing. The other thing is, there's lots and lots of reasons for why our liver may look abnormal on ultrasound. And just because the ultrasound says you have a fatty liver, it doesn't mean that. Ultrasound will show you what's called increased echogenicity. And increased echogenicity can be fat, it can be scarring, and could be inflammation. So again, for the patients who lack classical cardiometabolic risk factors and are not overweight or obese, we have to be very mindful to look for other causes of liver disease.
Okay, thank you.
The only thing that I would add to that is skinny patients can also have, if they have 4 cans of soda per week, it increases their chance of having fatty liver disease by 45%. And you can diet all day, but if you go get your boba for that day, then it increases your chances too. So packet foods, foods with preservatives and with sweeteners, carbonated beverages with sugars are, you can be skinny, but if you're having those, it can still increase your risk.
Yep, that was my mom. And when we got the results, we went to do the lab work, and then she has high blood pressure, she has cholesterol, and she has a fatty liver. And then I was doing really good. And then she's like, I think they missed, this is yours and that one's mine. And I'm like, excuse me, it says your name on the top and you're the one that's drinking a lot of sodas and eating tortillas. I'm really active. I know I'm obese, but I'm really active. But then I came with everything really good and she came with everything really bad. Yeah. And now she lowered the sodas and now she's active. And I'm like, okay, I guess you're going to turn on the next time that we go for labs. You're going to be doing better. Yeah. So thank you so much.
Of course. Okay, I think the gentleman over here will be next.
Oh, this is?
Okay, he can be, okay, off he can be now. And I just saw his hand being up for a long time. Thank you.
That's very nice of you. Thank you. Dr. Garcia, I understand that we should change proton pump inhibitors at certain intervals. I am curious what your feedback is. I've got somebody on Pepsid. I've got somebody else on Protonix. I've got somebody else on Nexium. How often do I know and when do I change them, please?
Yeah, so guidelines say that you should only change PPIs once. Really? Yeah, because and then you need to actually investigate why they're not working very much anymore. In terms of H2 blockers, one thing that I didn't mention, but they are known to have tachyphylaxis, meaning that they're going to stop working eventually. And so that's why they're not recommended for long-term treatment in GERD. It's because they ultimately will stop working. They're really good for heartburn symptoms that come up once in a while. You're feeling it, you need to take it right spontaneously, but they're not good for long-term treatment. And like I said, usually once you can trial somebody on PPI, you can increase the dose and see if that helps. And then if that PPI doesn't help that patient, you can switch them once before investigating further, but you shouldn't keep switching them because they are not going to work. That's evidence that there's something else going on. We need to investigate a little bit more. You're welcome.
So I was on a PPI and we just learned, I was taken off, was told that because it causes osteoporosis. So I've been having symptoms. I've had 2 hiatal hernias. The second one was a fix. I do have a lot of acid and I'm feeling uncomfortable. So before I go back, my question is can you only be on there for so long on the PPI?
Can you no. You can stay on a PPI for long term. What is, and like I said, there's nothing that's really shown, there are no trials that shown that those adverse effects, that the PPIs cause those adverse effects besides GI infections. So if you do have, objective evidence of gastroesophageal reflux disease, if you do feel like your symptoms are well controlled on a PPI, that is an indication to stay on a PPI for long term.
Thank you.
You're welcome.
So we do a couple questions offline,
Yeah.
online.
Are fiber scans available without going through a GI specialist first in Fresno?
The short answer is yes. Your primary care provider can order a fiber scan that can be done at Community Regional Medical Center endoscopy. And it's just like any other test, just like an ultrasound or a CT that your doctor can order without having to go through a GI specialist.
Okay. And then one of these slides mentioned hepatic hypothyroidism. Can you elaborate on how that is related to fatty liver?
Oh, shoot, I forgot to mention that. I think I was nervous about the running out of time. So one of the new drugs, resmetirom, it's a fascinating drug. And we all know that in order to have a healthy metabolism and not to be overweight, we really have to have a healthy and functioning thyroid. Well, kind of the same true is for the liver. So what we're doing with resmetirom drug, we're treating hypothyroidism in the liver. Localized hypothyroidism, there's different receptors from the rest of the body. So treating this local hypothyroidism causes the liver to lose fat, therefore inflammation is reduced, and remarkably, we see reduction in fibrosis. So thank you for asking that question. Let's go back to the audience questions.
Thank you for doing this. My question is, if people have like rheumatoid arthritis, psoriatic arthritis, or just psoriasis, can the PPIs affect their disease? Can they get flare-ups or even allergic symptoms from it?
I have not heard of that, and there's been no evidence that proves that. I think what you have to think about is the medications that you're taking and if there's any interaction. But patients can take PPIs with those diseases.
Mhm. And what's the threshold for Tums, since it's calcium? That people can
Right.
get kidney stones or they can get other
And so that's what I'm saying.
complications?
So Tums, there are adverse effects. And
Yeah.
so, like I said, it's for an as needed kind of basis. But if
Mhm.
you're finding that you're taking them with every meal, you're taking multiple, that's already too much. You should not be taking them with every meal.
Hey, thank you.
You're welcome.
Yeah,
Okay.
I think
The red shirt over there. Thank you. Sorry, I don't know you guys.
Hello, thank you. I have a friend who wanted to be here. He's like 48, male, pretty healthy, big, kind of bigger, just stockier guy, but otherwise healthy. He wanted to ask, why would I have, this is a GERD question, by the way, why would I have extreme GERD with long COVID, then slowly nearly go away after more than half of a year?
That's a really good question. It might not be GERD with long-term COVID. The other thing is long-term COVID can actually cause, or it's an infection. So I would think about some kind of hypersensitivity or functional disorder, some kind of disorder of the gut-brain interaction that can actually be causing this feeling of GERD that is not getting better with PPIs. And so that's when, doing the Bravo or the wireless pH monitor and endoscopy would actually be really helpful.
Thank you.
Welcome.
I have a second question about a course of omeprazole. So you're having GERD and then you take omeprazole and you've only taken two doses of, say, an 18-pack course or whatever, and you suddenly feel better, like you could discontinue it.
Mhm.
Is that against recommendation, or should you continue the full course if you start feeling
No,
better?
I would recommend taking it for 8 weeks. And then you can stop using it. And if you feel better, I mean, we're supposed to stop it. And so I think, the PPI can really be helpful in terms of controlling what we haven't seen, which could be, the erosive esophagitis, that might be in the esophagus that you're feeling. The omeprazole is going to treat that. And then it's actually a lot better after you stop.
Thank you.
You're welcome.
Good morning, and thank you for this conference. I had an endoscopy 10 years ago, and it's coming up time for the next one. And they were looking for GERD. And what they found is that I guess the food was settling or not going all the way through. Would I go through my primary to ask to see if I could have another endoscopy? I don't remember who recommended last time.
Yeah, you can ask your primary doctor to refer you to a gastroenterologist who could do your upper endoscopy. That's what I would do.
Okay.
Yeah.
Thank you.
You're welcome.
Yeah, I was diagnosed with a hernia and then a hiatal hernia. Is there anything, and I think my doctor answered this, but I can't remember, but is there anything that can reverse that? The other question with that is it true you're not supposed to lift up to a certain amount of weight if you have those?
Yeah, so what happens with hiatal hernias is you have increased abdominal pressure. And so when you're lifting something up, if you can imagine, you're kind of straining a little bit, you're holding your breath, and that's going to increase the pressure in your abdominal cavity. And that can make different types of hernias worse. In terms of reversing them, they really can't be reversed unless you undergo some kind of surgical intervention, or with the hiatal hernia endoscopic intervention. Yeah, you're welcome.
1 second, let's not neglect our online listeners.
All right. So Suzanne is asking, to keep muscles during weight loss, how many ounces or pounds of protein must be eaten if you weigh 200 pounds?
so. It's 1.2 to 1.5 grams per kg. So
100, about 100 times
100,
that.
yeah.
So 1.2, 1.5 times 100, Suzanne. The next one that we have to go off of the nut questions. I love to eat nuts, all types. How much is too much?
Well, I mean, anything that is consumed in excess is bad for you. I mean, even drinking excess water can be bad for you. So I would say, probably kind of a good amount of nuts to eat is like a handful a day. If you're probably eating a bag a day, you're giving your body unnecessary calories. And you remember what happens with unnecessary calories. We have free fatty acid production, and then all kinds of bad things happen. Please. Mhm.
Yeah, I've had GERD for several years, and it came to the point I was going to the California disease. Oh, put it higher. I've had GERD for probably 10 years, and I was getting what do you call them? Endoscopies. I had one done at a doctor's office, and they found that they couldn't get the tubing down. So they used a pediatric tubing, and they still had problems, so they canceled the middle of the procedure and sent me to St. Agnes, where I had it twice. And then I started having issues with more GERD symptoms. And my doctor sent me to ENT, and they said that I had inflammation, severe inflammation around the voice box. But I've always had issues with swallowing, some of the symptoms you talked about earlier. The pain. I have osteoporosis. I was diagnosed about 7 years ago. So about 2 years ago, when they put me on a PPI, it really bothered me because the doctor put me on 40. I don't like to take pills. So I asked him if after the endoscopy, if he could lower it to 20. He said, okay. Over time, I changed my diet, exercise, and I felt that it was improving. But I talked to my primary and asked him if I could stop it because my symptoms were less. And he said, if you can handle it, like, with what you're doing, he goes, I'm okay with it. ENT told me don't use Tums because your issues are way beyond. So that's what happened. But my concern was with the PPI, the gastro specialist told me that reevaluate after a year because of my bone issues. So I asked the doctor if I could just stop it because, I'm going to have a DEXA scan. I get them every 2 years. And I don't know what to expect now, but I don't want to take a PPI. Is it okay? I mean, so my question is, are some individuals able to do well and control it without PPIs or?
I think for me, my views, you seem to have developed complications from chronic gastroesophageal reflux disease. It sounds like you may have developed a peptic stricture, and it might have been so narrow. It looks like one of the pictures where we had to take the pediatric endoscope and put it through. And so for you, I think if you're able to control your symptoms on through lifestyle modifications, that's really good. However, what happens when you have a stricture is that actually blocks the acid from coming up. So many people that have peptic strictures, they stop feeling their acid reflux disease, and then they start developing difficulty swallowing. And it's because that stricture is actually now the barrier. But then you can't swallow. And so I would I think that if it's controlling your symptoms, that's really good. Keep up with your endoscopy so you can prevent the complication again. And if you've been doing well off of the acid suppressant and you haven't had recurrence of the complication, then I would, yes, empower you to keep going with the lifestyle modifications.
A previous gastro specialist, I dropped him because I switched over to Medicare Advantage. But he wasn't seeing patients in their office. And when my time came around, the following year, he wanted to see me just at the hospital. And I said, no, I had complications at the hospital. The second time I've had complications because of the strictures, the difficulty with swallowing. And so I switched over to another doctor. And what he told me was, this doctor told me, you have strictures and you're going to be needing endoscopies for the rest of your life. And that really bothered me. That really bothered me. So then when I finally did have another endoscopy, they said there was no strictures. And so it confuses me.
Yeah. And I think that there can be, and we can talk about this after. I would love to talk to you about it more. There can be other things that can be playing a role.
Okay. Thank you.
Thank you.
So Thank you for all of your questions. I know you have more questions, but our Mediterranean lunch is awaiting us.
It's going to be outside, so you can access it through 136 or through the front door that you came in. Please enjoy. There's fitness outside and the health fair, and thanks for awesome speakers. I was looking for some earlier. Thank you.